Good morning, Dr. Marco.
Good morning. Can the host allow me to share the screen so that I can just put my presentation up?
Yes, I've allowed you.
Can you see my screen?
Yes, we can see it.
Okay.
Recording in progress.
Okay, so good morning, everyone. I hope you can all see my PowerPoint presentation. We'll be switching between my presentation and one or two videos from YouTube. So I hope you can all hear me so that we can go ahead and start. Somebody please confirm.
Yes, kindly proceed, Doctor.
Okay, so today we are going to have two topics. It's pretty compressed because glaucoma is a big topic and neuro-ophthalmology is a big topic. So we're just going to touch on the relevant things that you're supposed to know at your stage. So for glaucoma, the main outline is that we're going to look at the definition of glaucoma, a little bit on the anatomy and classification of glaucoma, diagnosis, medical treatment, and surgical treatment. We won't go into details because it's beyond the scope of our presentation and our timings. So it's just touching on a few things here and there that you should know. So glaucoma is an optic neuropathy, meaning it's a disease of the optic nerve. with the characteristic appearances of the optic discs and specific visual field patterns of the visual field defects that may or may not be associated with increased intraocular pressure. So we are going to look at these particular things I've pointed out, the optic neuropathy, the optic disc, visual field defects, and a little bit on the intraocular pressure, because these are the relevant things that you should know regarding glaucoma. Glaucoma is the second leading cause of blindness after cataract, and it's the first leading cause of irreversible blindness. So it's a very important disease to understand. And let's quickly look at the anatomy of the optic nerve head. You've done this in previous topics. So when you do a fundoscopy, you're going to be able to visualize the optic disc and the macula. The macula is usually temporal to the optic disc. So when you magnify the optic disc, and when you're looking at the optic disc, you're looking at this through a ophthalmoscope. And you've done an examination of the eye. And when you look at the magnified view of the optic disc, you'll find that it has blood vessels radiating from the center. You have the veins, which are slightly darker and bigger than the arteries. You have the center of the optic disc, there's a pale area called the optic cap. It's a little bit depressed and a bit yellow. The rest of the optic disc should be about around pink in color. Now, when you look at the cross-section of the eye, you'll find that the optic disc is basically a congregation, if I can put it like that, of the nerve fiber layer. Remember, the retina has 10 layers. So the nerve fiber layer, they all accumulate at the level of the optic disc and exit the eye and go all the way to the brain. And we'll look at the visual pathway. So these are the 10 layers of the retina that you know of. You've done this in anatomy. And one of the main thing is that the 8th layer is the ganglion cell layer. And then you have the axons of the ganglion cells, which are now forming the nerve fiber layer. So these nerve fiber layers, they all come together and accumulate or congregate at the level of the optic disc and exit the eye and go all the way to the brain, and we'll look at the visual pathway. Another thing that is important to know is that the eye has a constant pressure of between 10 and 22. And this pressure is maintained by aqueous. Now, aqueous is a fluid that basically bathes the internal structures of the eye, nourishes the eye, and exits the eye through a certain pathway. So when you look at the cross-section of the eye, you have the ciliary body, and the ciliary body is found in the posterior, basically in the posterior chamber. And the aqueous is formed in the ciliary body and it flows into the posterior chamber, then out through the pupil and into the anterior chamber. The anterior chamber is the space between the cornea and the anterior surface of the iris. And from the anterior chamber, it exits the eye through the trabecular meshwork. This is a sieve-like process which is found circumferentially at the junction of the cornea and the iris. So from the trabecular meshwork, the aqueous moves out through a canal, it's called the canal of Schlemm, and then out through the episcleral venous plexus and is absorbed into the ocular circulation. And when you look at the front, when you look at a patient from the front, you'll see the iris there. And you'll see, you will not be able to see the angle by looking at the patient from the front, but the angle of the anterior chamber, it's all circumferential, it's all round, and this is the pathway through which the aqueous drains out of the eye. So it's very important to know and to understand this anatomical flow of the aqueous all the way from the ciliary body posteriorly into the posterior chamber, through the pupil, as you can see in this flow diagram, into the anterior chamber, and out through the trabecular meshwork, canal of Schlemm, episcleral plexus of veins, and the ophthalmic veins. Now, the obstruction of aqueous, mainly at the level of the trabecular meshwork, what that would mean is that if the aqueous is not able to flow out, then the aqueous is going to accumulate in the eye, and the eye pressures are going to raise, and that's when you have problems related to glaucoma. So let's look at the classification of glaucoma. So that was a brief outline just on the anatomy. So glaucoma can be divided into acquired and congenital. And of the acquired type, you can have the primary, second, and secondary type. And of the primary type, you have the open angle and closed angle. And of the secondary, also the open and the closed. And we're going to look briefly into this. So when you look at the primary glaucoma basically mean there's no other ocular structure that has a problem, that has a disease. The eye just has a problem from the glaucoma, but the eye has no other ocular disease. Now, as I said, in primary glaucomas, you can have the open or the closed angle. So in the open angle, it generally means that the space between the cornea and the iris is open. So the trabecular meshwork has some resistance. There's some accumulation of debris and materials around the trabecular meshwork area, and the aqueous, it can flow very well from the posterior to the anterior chamber, but once it gets to the trabecular meshwork, there's some blockage. And once a blockage occurs, the aqueous is not able to flow out, and there's accumulation of the aqueous within the anterior chamber, and the pressure of the eye rises as a result of this. Now, characteristic of the primary open angle glaucoma, this is the most common form of glaucoma we have, especially in African eyes. And the pressures are high, more than 21 millimeters of mercury. The angle, as I said, it's open in appearance. When the angle is open and the pressures are high, the optic nerve head, the ONH means the optic nerve head, it gets damaged. And this is because when the pressures are high, in as much as this is occurring in the anterior segment, the eye is not functioning at an optimal environment. And there's a lot of ischemia and mechanical pressure on the optic nerve head, and as well as the cells that are in the retina. As I said, we have the ganglion cell layer and the axons. So the axons of the ganglion cell layer, they die off. The ganglion cell layer themselves die off. The optic nerve head starts undergoing a lot of ischemic changes and mechanical processes. So accumulation of fluid in the eye is not healthy, and this causes the damage that we are going to see. Then, because the eye is not able to see well as a result of the damage to the optic nerve, you have what is called visual field loss, meaning you're not able to see, especially your peripheral vision, like you can see in this second picture down here. The axons are dying off, the ganglion cells are dying off, so you start losing your peripheral vision, and in advanced symptoms, you have what is called tunnel vision. Patients are usually asymptomatic in primary open angle glaucoma. It's low, insidious in progression. So, and one eye is usually affected faster than the other one. So it's bilateral but asymmetric. So now let's look at primary angle closure glaucoma. So in primary angle closure glaucoma, the cause is a little bit different. What happens in the patients who are at risk of developing angle closure glaucoma, the peripheral iris bows forward. So there's a bulge in the peripheral iris. And what happens is that when the iris bulges forward, it mechanically blocks out the drainage system at the level of the trabecular meshwork. So you find that the fluid is not able to the aqueous cannot flow from the posterior chamber to the anterior chamber. And this is mainly in eyes that are really small, and some of the races like Asians and they say Eskimos, basically if you have a relatively smaller eye, then the structures in the eye are pretty crowded and the iris gets stuck onto the lens. So the aqueous is not able to flow from the posterior chamber through the pupil and into the anterior chamber. So it accumulates in the posterior chamber and it bulges, the iris bulges forwards and occludes the trabecular meshwork and no drainage takes place. So angle closure, acute angle closure glaucoma, the pressures are very high, usually about 60. The angle is closed. The pupil is mid-dilated. In these patients, their pupils cannot react to light. The corneas are very, very hazy because of the pressures being very high. The conjunctiva is quite injected. The eye is very, very, and the patient is usually in a lot of pain. And they have a headache and the vision is lost, as well as they might complain of nausea and vomiting. So if you suspect a patient has these symptoms, they come with acute eye pain, redness, nausea and vomiting. You look at their eye, it's quite red, the cornea looks hazy, then it's a patient who you can highly suspect has an acute angle closure glaucoma. And also sometimes because the pressures are so high, they say when they look at a light or a light source like a bulb or just one point light source, they'll tell you they see rainbows around the light. So we call those halos, like a circumferential rainbow around the light. Those are signs of very high eye pressures. So now let's move on to the secondary glaucoma. So we have looked at the primary open angle and angle closure glaucomas. Now let's look at the secondary glaucomas. In these cases, the pressures are increased. IOP is intraocular pressure. The pressures are increased as a result of an identifiable abnormality in the eye. And we are going to look at just a few of them. There are so many, but we'll look at a few. So for example, if you've had trauma to the eye with bleeding of the iris vessels into the anterior chamber, these blood vessels, the red blood vessels can block the trabecular meshwork. And when the trabecular meshwork is blocked, there'll be no flow of aqueous out of the eye and the pressures can go up. Also, if you've had trauma and you have a cataract that has the anterior capsule has ruptured and all the lens material is blocking the outflow area of the trabecular meshwork, then the pressures can go up. If you have inflammation in the eye and you have accumulation of cells in the eye, either pus or just white blood cells, they can block the trabecular meshwork outflow and the pressures can rise. Also, in some cases, especially diabetic retinopathy, where they have new vessels forming, neovascularization as a result of proliferative diabetic retinopathy. These new vessels that are forming on the iris can also form on the angle of the anterior chamber, and they can block the anterior chamber angle and the pressures can rise. So it's always important to know that if you have any other trauma or a diabetic or an inflammation in the eye, then the eye pressures are at risk of going up. So now let's move on to the congenital glaucomas. So in congenital glaucoma, you have primary and secondary, but we're just going to look at the primary type because these are the most common. So when you look at this child has really, really big eyes, and this is a sign that the pressures are high. So congenital glaucoma is usually the primary type. It usually is evident at birth up to the age of 3 years. So that means a child can be born with a glaucoma, or it can manifest anytime between when the child is born to 3 years of age. Most of the times it manifests within the first 1 year of age. So what happens in these children is that there's an abnormality in the anterior chamber angle development. So there's what we call a trabeculodysgenesis. So the trabecular meshwork does not form properly while the child is intrauterine. And because the trabecular meshwork is not formed well, then the aqueous is not able to drain out of the eye properly, and the pressures subsequently rise. So there are certain clinical features that you can identify. Most commonly, these children, how they come is that the child's eyes are really, really big, and we call that ophthalmos, so very big eyes. And also the corneas can be quite hazy because so when the pressures are high, the corneas become hazy. They no longer become clear. So the classical symptoms that the child has, so one of the things the patient's mothers will complain of is that the child has a constant tearing, even when the child is just not upset. When they're not crying, there's a lot of tearing, or what you call epiphoria. And then photophobia, when you take the child out to a place where there's light, they're not able to withstand the light. They don't want light, and also blepharospasm as a result of the irritation from the high pressures. Also, as I said, there's buphthalmos. Buphthalmos mainly means a big eye, what we call an ox eye. If you look at an ox or a cow, they have really big eyes, and that's how actually the patients present. And this is because the eye is not very, the structures are not strong enough to withstand those high pressures. And when in children, that is below 3 years, so when the pressures rise, the eye actually balloons out, just like a balloon. So, but by the time the child is 3 years old, the eye is supposed to withstand that kind of pressure, and they don't have buphthalmos if the glaucoma presents after 3. But below 3 years, the eyes really are big, and there's increased corneal diameters. As you can see, the corneas are very, very large in this case. And as I said, the corneal haziness. Okay, so let's go to the diagnosis quickly. So you can use a torch, which most of you will be using, especially if you're out in the field, or you can do, and also you should do what is called tonometry, which is measuring of the intraocular pressures, as well as fundoscopy, observing the optic nerve, and perimetry, which is the visual field. So a torch, what can you pick out with a torch? We've talked about the cornea being hazy, especially in angle closure glaucoma. We've talked about red injected conjunctiva, also a fixed dilated pupil in angle closure. And also in angle closure, if you shine the light from the side of from the temporal aspect of the eye, there'll be a shadow that the iris casts on the nasal aspect. This is specifically in acute angle closure. And that shadow is in the shape of a crescent, or what we call the eclipse sign, like when you have the eclipse and there's a crescent shaped when there's an eclipse. So they call it the eclipse sign. So these are things you can pick out with the torch. And also, as I said, in congenital glaucoma, any child who has big eyes, that's not normal, send them to the ophthalmologist immediately. Now, when it comes to tonometry, you can be able to measure the pressures. As I said, the normal is between 10 to 22. There are different methods of measuring. You can use the Goldman applanation tonometer, which is fixed onto the slit lamp. If you come to the clinic, you'll see us using a machine called the slit lamp, and this is able to accurately, it's a gold standard of measuring the intraocular pressures. Also, we have a handheld version. It's called the Parkins tonometer. We also have other devices that you can use that are more digital. There's a tonopen. But if you don't have anything and you suspect a patient has very high pressures, you can actually like ballot the eye with your fingers. You just use your index fingers and touch and like press on the patient's, tell them to look down, press along the eyelid, and then feel. If you're not sure about the consistency, you can test with your eye and the firmness of your eye and examine the patient and compare the firmness. And most of the times when the pressures are high, the eyeball is very hard. Other more traditional methods are the shots. We don't use that too much anymore. Then like in the clinic, you have the non-contact tonometers, and we also have the eye care tonometers. So these are just different ways of measuring intraocular pressure. And if the pressure is high, these are patients who should be managed accordingly. When it comes to fundoscopy, remember we said tonometry, now fundoscopy, you should be able to identify the optic nerve head. And the main thing is that the optic disc, how we usually tell that the patient has glaucoma is that when you have glaucoma, the nerve fiber layer starts dying off. The nerve fiber layer is represented by the edge of this cap. Remember we said there's a little depression there. So the edge of the cap to the edge of the optic disc, that's a nerve fiber. So when it starts dying off, the cap increases and this area called the neuroretinal rim, becomes thinner. So the more advanced the glaucoma, the bigger the cup and the less the neuroretinal rim. So how we usually document this is that a normal disc, we divide it mentally into 10. Then we are able to estimate how much of the cup occupies the whole disc. Usually it's about 3 sectors out of 10. So we document this as 0.3. So and we call this a cup to disc ratio. So as the cup increases, the neuroretinal rim gets thinner, then that means the glaucoma is getting more advanced. So like in this case, the cup to disc ratio is about 0.6, 0.7, 0.9, and eventually 1 when there's no neuroretinal rim remaining. So the normal cup to disc ratio is about 0.3 to 0.6. Anything above 0.6 is suspicious for glaucoma. Also, if there's asymmetry between the two eyes of more than 0.2, then that is also suspicious for glaucoma. So let's look at this diagram on the right. So the first picture, you can see the cup to disc ratio is very small. It's about 0.2. And as the glaucoma is increasing, that means more of the nerve fiber layers are dying off. The cup to disc ratio is increasing here to 0.4. This is about 0.6. This is probably about 0.8. And this is 0.9 and eventually 1. So when you have a cup to disc ratio of 1, that means the glaucoma is quite advanced and the patient basically has almost no nerve fiber layer remaining, and most of the times this patient is already blind. Also, the optic nerve gets quite pale, and the vessels start moving, shifting nasally as the disc, as the cup to disc ratio increases, and with time the vessels look like they're climbing out because the cup gets very deep and excavated. It looks like the blood vessels are climbing out of the optic disc because it's very deep, and we call this bionating of the vessels. So these are signs that the patient has quite advanced glaucoma. Now let's quickly look at the visual field. A visual field basically means when you're looking straight, what can the periphery of your eye see as you're looking at one point straight ahead? And if you cover each eye, you'll find that there are limits. Let's say if you cover your left eye and you're looking straight, how much can you see superiorly? How much can the eye see inferiorly? So superiorly, it's about 60 degrees, inferiorly about 75 degrees. Temporally, it's much better. It's about 110 degrees, and nasally, it's 60 degrees. So this, we can document it on a chart, the normal visual field. And as I said, for glaucoma, there's reduced visual field, okay? So we have a manual and automated ways of documenting the visual field. We usually use what is called the Humphrey visual field test. And this is a printout of the visual field. So a normal patient, for example, with this picture on the left, this is what a normal visual field test looks like. This dark area is a blind spot, which represents where the optic nerve exits the eye, the optic disc head. However, if a patient has glaucoma and they have lost a lot of their axons and the cup disc ratio is increased, then they're going to have loss of peripheral visual field, and then they remain with the central visual field, and we call this tunnel vision. As you can see, this is what maybe the patient sees, and this is when we document it on our visual field test. This is the printout that you get. And as the glaucoma progresses, even this tunnel vision is eventually lost and the patient goes blind. Now, if you don't have any equipment to measure the visual field test, you can actually do a confrontational visual field test. This is well documented well explained in your Hutchison's. So just read through your Hutchison's, how to examine the eye and how to do a confrontational visual field test. And it just gives an idea, especially in quite advanced visual field loss, if you don't have any other way of documenting the visual field. So treatment, let's quickly go to treatment. So you can use medical treatment, which are eye drops and sometimes some oral and intravenous medication, or you can do surgery. Medical treatment usually has two main functions, either to suppress aqueous production or to increase aqueous outflow in order to reduce the pressure. Surgical treatment, usually we just increase the outflow of aqueous from the eye. So there are different kinds of medication. We have beta blockers. Most commonly, we use timolol. We also have alpha adrenergic agonists. Mostly, we use the brimonidine. So there are different kinds of these drugs, but I'll just bring out the most obvious ones, the most common ones. We have cholinergic agonists, the miotics, pilocarpine, mainly used in angle closure glaucoma. Also, we have oral carbonic anhydrous inhibitors. Acetazolamide is the most common one. You'll hear us prescribing Diamox. And this is especially when the pressures are very, very high. We want to get the pressures down. We give them oral medication. Other forms of medical treatment, we have prostaglandin analogs. Most common ones are those ones that are listed there, latanoprost, travoprost, and bimatroprost. All these are available in the market. In case the pressures are very high and we need to bring the pressures down, we have intravenous mannitol and oral glycerin. And these are used especially in also acute angle closure when the pressures are very, very, very high. And they are hyperosmotic agents which help to bring the pressures down considerably. Then let's look at surgical management. There's a lot of surgery that can be done in glaucoma, but we'll just look at the main ones. And I won't go into laser because of the time, but when we look at congenital glaucoma especially, we usually do either goniotomy or trabeculotomy. And in adult or the normal, in adult glaucomas or acquired glaucomas, we do the trabeculectomy. There are other procedures that we do, but we won't have time to go into that. So congenital glaucoma, as I said, is a problem of the trabecular meshwork. It's a trabecular dysgenesis. So you can either go in with a needle and open up the trabecular meshwork manually, and we call that goniotomy, or you can use some little probes to access the trabecular meshwork and to open it up. In trabeculectomy, this is now what we usually use, and you'll see this mainly in adults who have undergone glaucoma surgery. We create an opening on the surface of the eye, manually create a window on the surface of the eye, and this window, it's going to connect the aqueous from the posterior chamber. We make a hole through the iris, so the aqueous flows from the posterior chamber into the anterior chamber, and then out of the eye through our little window. So when you look at a patient who's had this procedure, you'll see they'll have a hole on the iris from which the aqueous flows, and there'll be a little bulge on the conjunctiva where the small window we've created, that's where the aqueous flows out, and they have a little bulge. And once the aqueous flows into this subconjunctival space, it is absorbed by the normal drainage system of the eye. So that was a very compressed talk on glaucoma. There's a lot you should go and read about, but this is basically what you need to know. And now let's move on to neuro-ophthalmology. So in neuro-ophthalmology, we are just going to look a little bit on the anatomy, visual field defects, papillary edema, optic atrophy, pipillary reactions, third nerve palsy, sixth nerve palsy. So there's a lot you need to know, but because of time, we'll just highlight the important aspects from this topic. So we look at the anatomy of the visual pathway. The visual pathway starts from the retina, from the rods and the cones. So from the retina, remember we said there are the 10 layers of the retina, and finally the axons of the ganglion cells, they all meet or congregate at the level of the optic nerve, exit at the optic disc or the optic nerve head. They exit the eye through the optic nerve to the optic chiasma, optic tract, lateral geniculate body, optic radiations, and the visual cortex. And we're going to look at this briefly. The visual cortex in the brain is mainly in the occipital area. It's also called the Brodmann area 17. When you do your surgery and or neurosurgery and I think neurology, you'll find that the brain is divided into various areas and they're named. So the visual cortex is Brodmann area 17. So as I said, when we start at the level of the retina, the photoreceptor layers, you have all these 10 layers, and then we have the ganglion cell layer there, and the nerve fiber layers. So this area is very important for you to know, because now the axons of the nerve fiber layer are the ones that are represented, or they all come together and they meet at the level of the optic nerve or the optic disc. I use those terms interchangeably, and then they exit the eye as the optic nerve. So when you have so this is just a schematic diagram showing representing the visual field. So we said we have the axons congregating at the level of the optic disc, and this exits through the optic nerve. So the optic nerve, when the axons exit there as the optic nerve, we have the optic chiasma. Now we are moving more into the intracranial region. So at the level of the optic nerve, at the optic chiasma, you find that the fibers from the temporal area of the retina, they do not decussate, okay? So they continue on the same side. However, the ones from the nasal side of the retina, they actually decussate to the other side, okay? And then from the optic chiasma, you have the optic tract. So these fibers, which represent the temporal fibers from the same side of the eye and the nasal fibers from the opposite eye, they all meet at the level of the optic tract. And at the optic tract, they move towards what we call the lateral geniculate body, which is the area where there's a synapse. So when the synapse there, and you have the second generation neurons. So this, from the lateral geniculate body, you have the optic radiations. And now the optic radiations are the ones that now also now move towards the occipital lobe to the area 7, the Brodmann area 17, which is the primary visual cortex. So we're going to look at now the most important thing, and we'll watch a very short video, is that you need to understand that the fibers that are from the temporal aspect of the eye, they're the ones that are able to see the nasal visual field, and vice versa. From the nasal, they're the ones that see the temporal. And we'll see this in the video shortly. But both eyes, when you open both eyes, there's a place where there's a big overlap, and both eyes can see the center. So I'm going to just start the video and you'll be able to understand and see this a little bit more. So please let me know if you're able to hear.
Doctor,
can you hear the video?
We can hear, but we can't see it.
Sorry?
We can hear, but we can't see it.
The cornea of the eye.
You can hear, but you what?
Cannot see it.
Huh? Okay.
We can't see the video.
Okay, what can you see my PowerPoint?
Yes.
Okay, can you see something now?
Not yet.
Just give me a minute. Are you still seeing the PowerPoint?
Yes, doctor.
Can you see my desktop?
No, I think you can end the presentation, stop sharing, and then you can reshare your screen.
Okay, so all right. Okay, so
Yes,
are you
you can see now.
Okay, so let me
eye
stop.
bends light rays.
Sorry, let me just. It's a very short video. Are you okay now?
Yes, yes. Thank you.
An eye has many of the features of a camera, starting with a lens to focus light. The cornea of the eye bends light rays and is primarily responsible for forming the image on the retina, the receptive surface inside the back of the eye. The visual image focused on the retina is inverted top to bottom and reversed right to left. The part of the world that you can see without moving your head or eyes is called your visual field. Each eye sees only a portion of this visual field. The visual field can be divided into right and left visual hemifields. The right visual hemifield is seen by the temporal left retina and nasal right retina, while the left visual hemifield is seen by the nasal left retina and the temporal right retina. The visual field can also be divided vertically into superior and inferior divisions. Note that the visual fields of both eyes overlap extensively in the central portion of each visual hemifield. This region defines the binocular field of view. Vision in the periphery of the field of view is strictly monocular, mediated by the most medial portion of the nasal retina. The center of the visual field projects its image onto the foveal region of the retina. On the retina, the highly specialized fovea has a dense concentration of small diameter cones and a one-to-one relationship between the cones and the bipolar and ganglion cells. Visual acuity is therefore especially high in this region. Now let's examine the pathway from the retina into the brain. This diagram shows a view of the base of the brain as seen from below. Note that in this view, the position of the two eyes is reversed. The axons of retinal ganglion cells exit the retina via the optic nerve. The optic nerve exits the eye in a region called the optic disc. Because there are no receptors in this region, nothing can be seen in the corresponding part of the visual field. This blind spot does not appear as a dark spot. Rather, it is simply a region from which we cannot obtain visual information. The optic nerves cross at the optic chiasm, which is located just anterior to the stalk of the pituitary gland. In humans, axons from the nasal retina cross over to the opposite side of the brain. Axons from the temporal retina project to their own side of the brain. After they pass the optic chiasm, the axons of the retinal ganglion cells are known collectively as the optic tract. Note that information from the left visual field is carried in the right optic tract, and information from the right visual field is carried in the left optic tract. The vast majority of axons of the optic tract terminate in the lateral geniculate nucleus, or LGN, which is the visual part of the thalamus. However, the axons of retinal ganglion cells also project to several other brain regions. Some axons of retinal ganglion cells extend to the superior colliculi, a paired structure on the roof of the midbrain. The superior colliculi help coordinate rapid movements of the eyes toward a target. Small bundles of optic tract axons also project to the suprachiasmatic nucleus in the hypothalamus. Cells in the suprachiasmatic nucleus are involved in the control of daily or circadian behavioral rhythms related to the light-dark cycle. Finally, optic tract axons from still other ganglion cells project to a collection of neurons that lies between the thalamus and the midbrain in a region known as the pretectum. This region is important as the coordinating center for the pupillary light reflex, that is, the reduction in the diameter of the pupil that occurs when sufficient light falls on the retina. The lateral geniculate nucleus serves as the primary relay nucleus for visual processing by the cerebral cortex. The right lateral geniculate receives information from the left visual field, the nasal left retina, and temporal right retina, while the left lateral geniculate receives information from the right visual field, the nasal right retina, and the temporal left retina. The spatial relationships among the ganglion cells in the retina are maintained in their targets as orderly representations or maps of visual space. The primary lateral geniculate nucleus has 6 layers, and input from the two eyes are maintained in separate layers within the LGN. From the lateral geniculate nucleus, information is relayed to the visual cortex. Most of the axons from LGN neurons form the optic radiations, which terminate in the visual areas in the occipital cortex at the back of the brain. In this lateral view of the brain, we see that axons carrying information about the superior portion of the visual field sweep around the lateral horn of the ventricle in the temporal lobe, a branch called Meyer's loop, before reaching the occipital lobe. Axons carrying information about the inferior portion of the visual field travel in the parietal lobe. The topographic order of visual information is maintained in the visual cortex. The fovea is represented in the posterior part of the visual cortex, whereas more peripheral regions of the retina are represented in progressively more anterior regions.
Okay, so I don't want to go into the different regions of the occipital cortex, but basically you have an idea from this presentation, and I'm going to send all these links to you. So I think let's just continue. I don't know if you can now see my presentation again.
You'll have to stop the
I have to stop
screen.
the
Yeah.
Okay, so. Okay, just give me a second. Okay, so we are back to the PowerPoint presentation. Is that okay now?
It's okay now.
Okay, good. All right, so let's, we've looked at the little video, and it's important to understand what I had just explained so that when, when you're looking at the visual field defects, you'll be able to know how they come about. So like in this part of the visual field, there's a central scotoma. That means just the macular area has been affected. However, if you dissect the optic nerve, or if you have a lesion at the level of the optic nerve, then that means the right eye, because this is the right eye, that's the left eye, the right eye will be blind. If, however, there's a lesion at the level of the optic chiasma, and there are many tumors that can present in this area, that means the nasal fibers are involved, and the nasal fibers are the ones that are responsible for the temporal visual field. So you'll have loss of the temporal visual fields in both eyes, and we call that bitemporal hemianopia. If at the level of the optic tracts or optic chiasma, there's a lesion there, it's going to affect the contralateral the contralateral hemifields of the opposite eye, as well as the right eye, the nasal aspect. So you're going to have what is called a homonymous hemianopia, and this is depending on where the lesion is, whether it's an ischemic or a tumor or a trauma. So you're going to have a contralateral, what you call a homonymous hemianopia. The visual fields can also be affected, and you'll get what is called a pie in the sky or pie in the floor, depending on where the lesion is at the level of the optic radiations, because some of the fibers, for example, the ones in the Meyer's loop, this one at the level of E, the Meyer's loop are the ones that are found in the temporal lobe, and they cause any lesion there, especially ischemia, can cause a superior quadrantinopia, also called a pie in the sky. However, the ones that are in the parietal lobe, the more inferior fibers, they form a pie in the floor. So you're going to look at this. You're going to look at this later on and try and understand how these visual field defects occur. Now, if you have a lesion at the tip of the occipital lobe, you have the homonymous hemianopia, but the macula is spared because right at the tip, the blood supply, especially this if you have an infarct of the posterior cerebral artery, that's the one that causes problems, many vascular problems at the level of the visual cortex. So there's a lot of anastomosis and collaterals forming at the macular area. So the macula is usually spared from posterior cerebral artery infarcts. So you'll have still a contralateral homonymous hemianopia, just like in the other, just like from the level of the optic tract, optic radiations, but the macula is spared. Sorry, we have to rush through this because of the time, but these are things you have to now go and read and consolidate afterwards. So it's very important for you to also understand the aspect of papillary edema. When you do a fundoscopy on a patient and you find that the optic disc edges are blurry and they look raised and the optic disc looks swollen, this is as a result of raised intracranial pressures most of the times if it's bilateral. So bilateral disc swelling is most likely as a result of raised intracranial pressure. And in early stages, the visual acuity is normal. But as the intracranial pressure continues to rise and the optic nerve continues to get affected, the visual acuity is affected in the late stages. But in the early stages, they have normal visual acuity. And as I said, the margins are quite blurry in these cases. So causes of increased intracranial pressures, most commonly space-occupying lesions, hydrocephalus, meningitis, encephalitis, abscesses, idiopathic intracranial hypertension, trauma that can result in subdural hematoma or subarachnoid hemorrhage. And you're going to cover all this once you do your medicine, internal medicine, and also neurosurgery rotation, where you'll see all these conditions. So it's important to know that when you see a patient who has raised disc margins, blood disc margins, the optic disc looks elevated, most likely it's as a result of intracranial, raised intracranial pressure. Now let's look at optic atrophy. So optic atrophy basically means that the optic disc looks white. Remember in disc edema or papillary edema, the disc is raised, but in optic atrophy, it starts looking white. And that signifies that there's death of the retinal ganglion cell axons. They are completely dead. So when you do a fundoscopy, the optic nerve or the optic disc looks pale or atrophic, and there's damage anywhere along the path of the retina, all the way from the retina level to the lateral geniculate layer where there's synapse. So any damage or any ischemia or any lesion, any tumor along that path can cause primary optic atrophy. And usually when a patient presents like this, like in this fundoscopic picture of a white disc, the patient is usually the vision is actually quite reduced, and most of the times the patient is already blind. Now, causes of optic atrophy, you can have primary causes or secondary causes. Glaucoma is one of the causes of primary optic atrophy. Also, if you have tumors along the visual pathway, either a pituitary tumor, the pituitary area, or an optic nerve tumor, or if you have trauma to the optic nerve, other there are some autoimmune conditions, multiple sclerosis, all this can cause primary optic atrophy. Secondary optic atrophy is mainly as a result of papillary edema, which you've seen is as a result of raised intracranial pressure, or papillitis. Papillitis is inflammation of the optic nerve, and this can occur in there are many causes of papillitis. Papillitis also causes unilateral disc edema. So papillary edema is bilateral disc edema as a result of raised intracranial pressure, but papillitis is inflammation of the optic nerve, where the optic disc still looks swollen, and the disc margins are blurry, but it's usually unilateral as a result of inflammation of the optic disc. So it's important to know that if a patient has optic atrophy, to classify it as primary or secondary, and you'll be able to at least know the etiological cause. Now let's quickly look at the pipillary reactions. So pipillary reactions as a result of either the parasympathetic or the sympathetic pathway. So the parasympathetic pathway when the parasympathetic pathway is stimulated, it causes pupillary constriction, okay? However, the sympathetic pathway leads to pupillary dilatation. So we won't go into a lot of the details, but the main thing is that you need to understand how the pathway comes about. So when you have light shining into the eye, remember we said that the optic nerve transmits the messages of has the fibers that go into the brain, and the fibers either decussate or follow the same side according to whether they're nasal or temporal. We've seen that. However, there are fibers that when you get to the level of the optic tract, some of the fibers are actually directed to an area of the midbrain called the pretectal nucleus. So the pretectal nucleus, we have also what is called the Edinger-Westphal nucleus, and this is where you have the pupillary, we're talking about mainly the, the pupillary fibers. So from the Edinger-Westphal nucleus, you have now the efferent pathway. So the optic nerve to the pretectal and Edinger-Westphal nucleus in the midbrain, that is the afferent pathway. Then the efferent pathway that's coming back to the eye comes from the Edinger-Westphal nucleus through the cranial nerve 3 and back to the eye and causes the pupillary constriction. So what happens is that you have a lot of decussation at the level of the optic chiasma. You have additional decussation of the pupillary fibers at the Edinger-Westphal nucleus. So there's a lot of decussation and mixing up of these fibers at all levels. What that basically means is that if you shine light on one eye, then you'll have constriction of the pupil on the same eye as well as on the contralateral eye. That's all it means. Because all the fibers, because the fibers decussate at the level of the optic chiasma, and also at the level of the midbrain, the pupillary fibers also decussate. So there's a lot of decussation. And with this decussation, you have similar, you have similar constriction on both sides. So if there is a condition whereby this, for example, this eye cannot see, when you shine light into this eye, then that means there won't be constriction on the opposite side. However, if this other eye can see, if you shine light and one eye is blind, it will still constrict. And we're going to look at a small video. So basically, we have this condition called the relative afferent pupillary defect. It's very important for you to understand this because it's basically the basis of why you're doing your assessment with a torch. And most of the times you're going to have a torch. So if there's a problem with the optic nerve, like this patient has a problem with the optic nerve of the right eye, when you shine a light into the left eye, the right eye will still constrict because of the decussation and the sharing of fibers at the level of the chiasma and the midbrain. However, if you shine a light onto the right eye, which is not able to transmit any impulses into the brain, the left eye is not going to constrict. Okay, so I'm going to, again, just, okay. And causes, let me just go back to this, causes of problems of the optic nerve that can cause the afferent pupillary defect, optic neuritis, which is inflammation of the optic nerve, any optic disease, or any optic nerve disease or retinal disease, severe glaucoma, trauma, retinal detachment, retinal infection. So all these things can cause problems to the optic nerve or the retina and inability to transmit the messages. So I'm just going to show you a very short video so that you understand this condition. Sorry. Just give me a minute. Okay, can you see the video?
Yes, doctor.
My job is to make college easier because students have a lot. In this patient, you will see that the right pupil consistently dilates as the light is swung toward it. This dilation is called a relative afferent pupillary defect. It usually signifies that an optic nerve lesion is present on the side of the dilating pupil. This test is the most sensitive and the only objective way to demonstrate a unilateral optic nerve lesion or bilateral but asymmetric optic nerve lesions.
Okay, we're almost done. Good. Let's quickly look at third nerve palsy. So the third nerve palsy is the oculomotor nerve. The function of the third nerve, it innervates all the extraocular muscles except the lateral rectus and the superior oblique. And we had said that also it's involved in pupillary constriction. Remember the fibers that come from the Edgar-Westphal nucleus run along the third nerve palsy and cause the parasympathetic constriction of the pupillary fibers. So, and also another function is to elevate the eyelid. So if you have a third nerve palsy, it means that the patient will complain first of, this is what is most obvious to them, that the eyelid is drooping because of the elevation of the levator palpebrae superioris is lost. That's a muscle that opens the eye. Also, they'll have double vision because the eye will be turning out. It's turning out and is deviated outwards and downwards. This is because of the unopposed action of the lateral rectus and the superior oblique. And another thing is that the pupil will also be dilated. So if you see a patient who has come with drooping of the eyelid, when you open the eyelid, the eye is deviated outwards and downwards, and the pupil is dilated, that's a sign of a third nerve palsy. The causes are many, mainly aneurysms, also ischemia to the optic nerve due to diabetes or high blood pressure, trauma, tumors, hemorrhage, congenital, idiopathic. So all these are causes of third nerve palsy. The main thing is that you should be able to pick these signs when a patient presents like this. So we'll also look at the sixth nerve palsy, which is the abducens. Remember the abducens, we said it supplies the lateral rectus. So if a patient cannot move their lateral rectus, that means they cannot abduct their eye, and the patient presents with horizontal diplopia. They have two images side by side. So like in this patient, when you ask them to look to their right, they can't, their right eye has the sixth nerve palsy. They cannot abduct the eye still looks straight. However, when they're in primary position, they're okay. When they're asked to look left, they're okay. So this is a sign of a right sixth nerve palsy because the lateral rectus is not innervated in that position. So what are the causes? Most commonly, when you have raised intracranial pressure, the sixth nerve is affected because of its long and windy course in the brain. So raised intracranial pressures is a common cause of this bilateral, usually bilateral sixth nerve palsy. Also idiopathic, tumor, trauma, meningitis, or ischemia can cause this. So I think we've come to the end. I'm sorry that we've had to congest so many things in one topic, but at the end of the day, you're supposed to go and read more on this, and I'll send the slides to your class rep. Are there any questions or any clarifications? Sorry, the time is even over. Yes, anything that you'd like to ask? Hello, can you hear me?
Yes, Doc, we can hear.
So if there's anything, maybe it's easier if anyone wants to clarify something to just send me what do you call it, an email, and or I'm usually at the dental school on Tuesdays. That's where we run our glaucoma clinics. But I'm going to send out this. This is basically a lot of textbook information that you just have to read, look at the videos, and consolidate everything that we have said. Okay?
Okay.
Yeah.
There's just one question on the chat box. Hello? Dr. Marco?
So I have seen the chat. This is as a result of it. This is a very complicated condition, mostly neurosyphilis related, and just go and read about it. We have papillary reactions is a whole textbook. So there's Agel Robinson, there's RAPD. I wanted to just bring out RAPD for you to understand. But Agel Robinson and Wanike and all sorts of other papillary reaction, it's a whole different ball game that I don't really want to go into. But the person who's asking, you can just call me with side chat, but I don't think it's important for you at this point. And I don't want to confuse the rest. The main thing, know what an RAPD is. That is what you're going to use. When I start talking about accommodation and light near reflex, because that's what Adele Robertson is, you're going to get confused. So first know the basics, which is what is the papillary, what is the papillary, normal papillary reaction? How does it come about? What is the RAPD? Then when you start going now into light near dissociation, accommodation, and all these things, it's a bit more of neuro-ophthalmology. It's not within the scope of this. For your exams, what I've taught you is what I'm going to ask. I'm not going to ask you this other complicated stuff. So George, you can see me on the side. Okay. So I'm going to Dr. Khan, I think.
Yes, doctor.
Please send me your email. I'll share these slides. I'll set all the exam questions from this slide. These slides, nothing apart from what I have taught is what I'm going to send. If you want to read on any other thing, that's fine. But this is what I'm going to set on, including even the videos.
Okay, no problem.
All right. So thank
you,
you.
doctor.
All right.
Have a
Bye.
great day.
Okay, you too. Bye.
Recording stopped.